In Section 7, we are going to briefly go through some technology-facilitated adherence enhancement data and family involvement evidence as well. So technology-facilitated adherence enhancement is becoming more common. There are a variety of commercial supports out there and apps. One study that was reported several years ago looked at technology-facilitated adherence enhancement in people with bipolar disorder and HIV. And it was a 30-day randomized controlled trial, or RCT, that compared two-way text messaging using something called the ITAB approach versus an active comparison to improve antiretroviral and psychotropic drug adherence. They found that the ITAB improved HIV drug adherence, but not psychotropic medication. That text messaging was feasible and low burden, so it's kind of low-tech tech. We're actually using this in some of our adherence research. So this could be a way to communicate with patients that is readily available. Another study, a 4-week observational study at 2 U.S. academic sites. Small sample, 12 patients with bipolar disorder, 16 with schizophrenia. They were all on stable oral medication. It used a wireless system to incorporate physiologic assessments and direct confirmation of digital tablet ingestion to track adherence. The system included digital health feedback system with an ingestion sensor embedded into the medications, which was activated by stomach fluids after ingestion, and the signals communicated with a wearable torso sensor. So the sensor facilitated tracking the date and time of drug ingestion, and the wearable sensor tracked activity and heart rate. The system was well tolerated. It did not adversely impact psychiatric status. But I think what was worth noting here is that the adherence rate was still only approximately 75%. So in spite of that, multiple intervention, this might be something that would work best in, selected groups of patients who are able to use these variety of components. Additional evidence in the literature on technology-facilitated adherence here specific to bipolar disorder is Colin Depp and colleagues piloted a mobile phone-delivered augmentation of a brief psychoeducation to improve self-management adherence and found that it was feasible and promising. Levin et al. Piloted an electronic pill cap plus phone-based, so it was text messaging system that assessed both adherence and delivered adherence promotion messages. So it looked promising also. Wentz piloted a 2-week ecological momentary intervention, so that's commonly used acronym of EMA, to improve adherence. Patients completed twice daily assessments about symptoms and adherence risk factors as they went about their daily routine, so they provided kind of frequent input, and the patients also received semi-customized automated feedback intended to neutralize risk factors such as forgetting or side effect concerns. Wentz and colleagues found that depression severity improved. I think that the take-home message that I'd like to make here is that simply monitoring medication taking is not enough. So you saw that earlier with the MEMS data that I showed you. Choosing to use technology such as an app needs to be something that the patient is motivated to engage with. This can be challenging for people with serious mental illnesses. Simple text messaging, even though it's pretty low tech, can be something that people can engage with and use, as evidenced by the studies of Depp and Levin. And then I want to talk a little bit about family involvement. So research suggests that social supports can be helpful. We found that in our bipolar disorder research, that 30% of people with bipolar disorder noted that either a family member or a significant other helped them to take their medication. However, we also found that 45% of family members or significant others, including parents, children, spouses, argued or advised the person against taking medication. So what's the challenge for the clinician is don't make the assumption that family members will be, pro-adherence, and they need to be assessed just like the patients to see whether they're going to be somebody that's going to help engage in care versus not. The key points to this sections are that clinicians can take advantage of technology to help with adherence supports. Low-tech technology like text messaging is fast, simple, and works well for many individuals, even those with cognitive challenges. Many clinical settings use texting for appointment reminders, but they could also be used in other aspects of care. Simply monitoring adherence behavior is unlikely to have long-term effects. So that Hawthorne effect usually becomes exhausted over time. People go about and do their thing, and adherence reverts to what is normal for that person. Apps can be useful for motivated individuals who feel comfortable using web-based tools. They can be quite helpful for those who like this technology, and there are a variety of apps out there, and they can be used to manage health really fairly holistically. Family support can be helpful, but clinicians should take an effort to understand the family member attitudes. Do not assume that family will universally or uniformly support adherence promotion.